Hello, I am Dr. Keith Burke. I'm a professor of behavioral sciences at the San Diego City College Alcohol and Other Drug Studies program. The AODS program is a state-funded vocational job training program for students who are studying to be certified alcohol and drug counselors in the state of California. The AODS program offers all the classes required to sit for the state certification exam, and it's a fully accredited program, meaning that the classes are college credits transferable to other universities and programs in the pursuit of further educational goals. So today I am going to talk about the use of motivational interviewing in the treatment of co-occurring disorders. Motivational interviewing at this point is a very well-established evidence-based practice in the treatment of substance use disorders. In fact, Miller and Rollnick, two psychologists who designed the principles and practice of motivational interviewing, I think back in 1983, at some point in the early 1980s, they were working with people who had substance use disorders. Specifically, they were working with problem drinkers. And through their research and study, they found that people with substance use disorders were often ambivalent or sometimes resistant to making changes in their lives, not only to address the substance use disorder, but all the associated negative consequences because of that substance use disorder. But since then, motivational interviewing has been applied in many other areas of behavioral health counseling, as well as medical treatment, and it's been found to be very effective in the treatment of other disorders, not just substance use disorders. Sorry, my slide was a little hung up there for a second. So since it was originally developed to treat substance use disorders, it's been applied to the treatment of mental health related conditions or problems. And there is now very strong research evidence for the effectiveness in motivational interviewing in the treatment of co-occurring disorders. In fact, SAMHSA, the Federal Substance Use Mental Health Services Administration, has recommended motivational interviewing as a frontline treatment intervention or a primary treatment intervention in the treatment of co-occurring mental health and substance use disorders. So overall, the goal of motivational interviewing is to increase motivation to make changes in order to improve one's situation. So we're trying to increase motivation. Related to that, then, we are attempting to decrease resistance to change. Take that off the board where there's less resistance, but it's also designed to help resolve ambivalence to change. So ambivalence is both wanting and not wanting something at the same time, or having mixed feelings about that. So we are also attempting to resolve that to where now all we're left with is the increased motivation to make changes in order to improve one's situation. We're changing "I can't do it" to "I can do it." Now, there is so much research on motivational interviewing at this point. I mean, essentially 40 years of research. And the research has consistently shown over and over again that when a well-meaning counselor uses a directive style and they attempt to instruct or suggest or educate or persuade or give advice to a client who's in a state of ambivalence or resistance, if they do that, that client's motivation to change decreases. Now, this is typically what happens with inexperienced or counselors in training who really just want to help people, and they have invested in whatever their particular field is, whether it's substance use or mental health or some other aspect of medical care, and they have ideas. The counselor has ideas. They have read some of the studies. They know what works. They know what doesn't work. In some cases, they may know what worked or didn't work for themselves. And so then they sit down with a client who has a condition that the counselor thinks that they can recognize. And so the counselor very helpfully tells them exactly what they should do. You should do this because this is going to help. Have you thought about doing this? Why don't you do this? And in doing this, it simply doesn't work. It does not increase motivation for people to change. People don't suddenly go, "Oh my gosh, yes, thank you. Like, I've been waiting for somebody to come around and give me just that piece of advice. And now that I've heard it, I'm going to make all those necessary changes in my life." So we have many clients with substance use and mental health disorders who are ambivalent or resistant to changing. And this is why motivational interviewing is now considered a primary or frontline approach, because using motivational interviewing techniques gets right after this issue and essentially designs a way of being with a client that avoids this directive style. We know that giving a client advice when they're in that state of ambivalence or resistance inevitably tends to lead towards arguing from the client about why that will or won't work, or defending whatever their view is or whatever their position is, or justifying where they are and why they're doing it this way or why this won't work, or withdrawing, shutting down, or in many cases, taking the side opposite of the counselor's directive. We'll talk about that a little further here, but when a client's in a state of ambivalence and they both want and don't want something, if the counselor tells them, you should want this, then the tendency is for the client to say like, well, no, actually, I don't want it, and here's the reason why. If the counselor says, you don't want this, then the client usually will take the opposite side and say, well, no, I do, right, and here's the reason why. And there's a real problem with that, because a client making an argument aloud for the less desirable position, at least from a clinical standpoint, may actually reinforce that position in the client's mind. So the client is ambivalent about whether or not they should stop smoking marijuana because it does help with their anxiety, but at the same time, they're in constant fear of being drug tested, by their employer, and their wife's giving them a hard time about it. Right, so they both do and don't want to do this. If the counselor comes in saying you should not smoke pot, well, then the client will tend to turn around and argue for all the reasons why pot is really helping in the case of the client's anxiety. So it's worth noting here that attempting to persuade, instruct, or give advice to a client who's in the action stage of change may be more successful. So research has shown once a client is already in the action stage and taking steps towards improving whatever their situation is, they tend to be more open to hearing persuasions or directives from counselors. But it's notable that these types of clients are usually already pretty motivated and don't need a lot of counseling, and so maybe less important to be using motivational interviewing. Now, motivational interviewing in the stages of change has a lot of application to working with co-occurring disorders. Helping people work through ambivalence and resistance is an extremely important therapeutic skill when you're working with the most challenging clients. The evidence has shown that motivational interviewing techniques have some of the strongest effectiveness for working with clients who are in the pre-contemplation, the contemplation, or the preparation stages of change. I'm not going to cover the stages of change very much more than this in this lecture. Stages of change is covered in many of the courses in the Alcohol and Other Drug Studies program at San Diego City College. But essentially what it says is people move through predictable stages in the process of changing. And in the beginning, the pre-contemplation stage is often associated with a form of a resistance. I don't have a problem. I don't want to make these changes. Contemplation is I'm thinking about it, but I'm not ready yet. Preparation is I am not taking steps towards making change yet, but I'm beginning to prepare for that. I recognize the importance of it. So the primary interventions by a counselor using a motivational interviewing approach are not directive. The MI counselor does not attempt to use persuasion, information, and advice giving in order to create change. Instead, the primary interventions by a counselor using a motivational interviewing approach are collaborative and center on actively working to understand the client's perceptions, goals, and frame of reference, meaning how the client sees this, what their thinking process is on this. So an MI counselor is working actively to try and understand that and asking targeted questions. So across the bottom, you can see it's scrolling. It's called motivational interviewing, not motivational telling. That's a common phrase used in training people in motivational interviewing to try and remind them, if you are telling someone what to do, then you're probably not practicing motivational interviewing. There is no actual motivational telling technique that's out there. Motivational telling is an oxymoron because the act of telling people what to do tends to decrease motivation. So an interviewer asks questions and tries to understand what's happening and how the person sees this and what their point of view is. So in MI, we're doing the same thing through the use of targeted questions, listening to our clients, responding them, and ultimately coaching them to help them try and find solutions, their own solutions to what the problem is. MI also strongly emphasizes acceptance. There's the phrase, meet the client where they're at, which is really accepting however they're showing up, accepting them in a resistant state, accepting them motivated, accepting that they're in conflict. We just simply accept it. Okay, so that's where you are. What are we going to do in order to try and help you in this situation? And lots of empathy. Now, the principal assumption for using motivational interviewing to develop and improve motivation is because studies have shown that motivation can be influenced by a number of things. So client and counselor perceptions can influence motivation, meaning that how I'm thinking about a situation may decrease or increase motivation, but also how my counselor is perceiving the situation. You just need to admit to yourself you're an addict. Until you admit you're an addict, then you're never going to be able to accept the things you have to do. Well, that may be a well-meaning intention in helping a person recognize the problems that their addiction or substance use is causing, but it's also a perception. And there's a lot of stigma and shame associated with addiction and substance use disorders. And so by emphasizing you just need to admit you're an addict, that perception could decrease potentially a person's motivation to change. Motivation can also be influenced by interactions and conversations. Everybody listening to this lecture have had that experience before, where after a conversation with a friend or a family member or a counselor or somebody that you're close to about a situation that you didn't know what to do, you ended that conversation and felt like, okay, yeah, I'm going to do that, or I know what to do now. And so the interaction influenced your motivation. In this example, increased it. And motivation can be influenced by other people and other environmental factors also. So things happening in your environment can definitely increase or decrease motivation. Perhaps if you're watching this as a training drug and alcohol counselor, you are really motivated to work on your assignment on Friday after you get home from work. And then you come home and your spouse says to you, hey, the neighbors invited us over for dinner and to watch that new movie. I want to go. You want to come with me? And so all the motivation you had to work on your assignment heads out the window, and you head over to the neighbor's house for some good food and a good movie. We also know that motivation is dynamic, meaning that it's not static. It doesn't stay the same. It's constantly changing. So what's true today might not be true tomorrow. And that goes both ways. So if somebody's not feeling particularly motivated today, they may feel more motivated tomorrow. But it also means that somebody who is feeling really motivated today may not feel quite as motivated tomorrow. And so the idea is that motivation can be cultivated and grown, or motivation can be lessened and destroyed. And a lot of that is going to have to do with, again, the perception of both client and counselor and the types of interactions and conversations that are had while somebody is in a treatment setting. So let's talk about the client-centered approach. So client-centered approach in motivational interviewing posits a number of very strong tenets. The first one is that it is not our job to direct and give unsolicited advice and tell clients what to do. That is a mistake. It's a mistaken understanding of what it means to be counseling somebody, and the research shows that it's not very effective. So in a client-centered approach, using the motivational interviewing framework, we see the client as the expert in his or her own life. The client knows about their life. No matter how long we've had the client in treatment, whether it's been a week or a month, or even if we've known the client for 3 months, it doesn't matter. 3 months compared to the client's own life, they certainly have a much better idea about what works for them and what doesn't work for them, and all of the many other factors that are contributing to this. And so we need to appreciate that the client is the expert in their own life. They're the one that has a lifetime of training in how to live their life, both good and bad. We are not the expert of how the client should live, nor are we the expert in what types of decisions that the client should make. So the client-centered approach in motivational interviewing says that before the counselor begins giving advice or suggestions, they should instead evoke or pull out from the clients their thoughts about the situation. Evoke or evocation is, again, one of those tenets of motivational interviewing. Stop telling people, instead ask questions so that you can pull out from them their thoughts about this situation, what they think might work and not work. And ultimately, the goal here is to help the client both see and find ways to solve their own problems. We are not, in a counseling setting, attempting to develop dependency. And if we are the ones that are always answering all of the questions and telling the clients what to do, and even if that did work, which the research says it typically doesn't, then even if it did, we're creating a dependency, and we're not going to be with that client throughout the rest of their life. So the MI approach is, hey, we're a coach trying to help intervene and teach clients to find ways to solve their own problems. Now, most people know the solution to whatever their problem is, even if they're reluctant to use it. The solutions are there. You simply need to bring them out. If you were watching this lecture, you could stop for a second and think about a time that you felt really ambivalent about something. I mean, a classic one is when a relationship starts going bad. Most of the time, people who are in relationships that start going bad, they know they have to get out of the relationship. They know that this isn't going to work any longer, but they're ambivalent because there's a part of them that still wants to be in the relationship. Even there's another part of them that doesn't want to be in the relationship. It's recognizing that it's going to be really hard. We live together. How are we going to handle that? Where am I going to go? I mean, there's all these factors. And so when the client says, I don't know what to do about my relationship, that's not actually true. Many times, at least in the example I'm giving you, they do know what they need to do. I need to get out of this relationship. It's just the act of figuring out all those other things is going to take time and process and counsel. So motivational interviewing recognizes the same thing. People know what the solutions are, even if they're reluctant to use them. So before we start telling people what to do, let's pull out from them. What are your thoughts about this? What are your thoughts about what would work, what wouldn't work, etc.? So there are many, many, many ways that you can get at this asking questions. These are just 3 examples here using a motivational interviewing approach. So how do you want to handle this situation? What do you think the first step would be if you decided to make this change? What have you tried in the past that worked? Because if it worked before, let's do more of that. Or what have you tried in the past that didn't work? If it didn't work in the past, then it's probably not going to work again. Now, we know when a client is encouraged and supported to use their own already existing strengths and identify their own ideas and resources to solve problems, they are way more motivated to change. So the client-centered approach is, you're the expert in your life. You have lots of thoughts about what you think would work or not work. And I want to know that because I'm curious. So let's talk about that. Tell me what your thoughts are. Let's see if we can work this out together. I'm here to be a support and a coach in a collaborative way to help you solve your own problems and make your own decisions. The motivational interviewing fundamentals, there are 4 posited by Miller and Rollnick. The first fundamental is acceptance. This is the meet the client where they're at phrase. So acceptance means a lot of things, but one of the things that it means is don't argue with your clients. So they may see things differently than you see, but at the end of the day, you're providing a service. Whenever you're in any kind of behavioral healthcare counseling setting, people don't have to do what you think they should do. You are getting paid either directly by the client or through a funding source like an insurer to be helpful and to provide a service. And so acceptance is accepting wherever the clients are. If they come in angry, if they come in ambivalent, if they come in resistant, if they come in whatever, like, okay, so I accept this is who I got here in front of me today. Acceptance also means honor the client's viewpoints, respect the client's autonomy, and affirm the client's strengths. So again, this is the client-centered approach. Respect client autonomy means you have the ethical right to do whatever you want to do, to live your own life the way that you see fit. Honoring the client's viewpoints, the client has a lot of insights about their own situation, and their viewpoints will give us clues to those insights. And so we need to honor those viewpoints even when we disagree with them, and affirm the client's strengths. The second fundamental principle is partnership. So as I mentioned already, the idea is that the client knows what's best for him or her, not the counselor. And so in partnership, the counselor is enlisted to support the client to meet his or her own goals. They're the expert in their own lives, and they know what they're willing to do and what will work and what will not. Now, supporting the client to meet their goals, that is essentially a reframe when people come into a treatment setting, recognizing that you didn't go get the client and put them into a treatment setting. Those clients came into treatment. And even if they were put into a treatment setting because of an intervention from a family member or a work situation or a court, those clients still had a choice in that process, and they decided to come to treatment where you are. And so that's presumably then their goal. They came to treatment to complete the treatment so that they can get that sheet of paper that gets them their driver's license back. Okay, well then let's support that. If they're here to complete treatment because it'll get their wife off their back, okay, great. If they're here to complete treatment because they want to learn how to manage their depression better, wonderful. If they want to stop using substances, great. The whole thing here, though, is that they are the client. We are providing the service, and so we're there to support them in meeting whatever his or her goals is. And if you think about it, it's kind of the same with any other service that's out there. If a client is going to, paint their bedroom, and they come to the paint store, well, if I'm the painter, I might have thoughts about what colors work and don't work, but if the client comes in and they really are saying they want a pastel purple, okay, I'm in the service of your goals. And if that's what you want to do, I'll help you find pastel purple. And maybe along the way, we could have a conversation about why you want to do pastel purple, and have you considered any other colors? And do you know anybody that has a pastel purple bedroom? And wow, the more that we're talking about it, I don't know if purple is really so good for me. And okay, well, if you weren't doing it in purple, what other kind of colors have you thought about? You get the idea, right? It's the same exact style of motivational interviewing. I'm accepting that you came into my door wanting a pastel purple bedroom. I am honoring that that's what your goal is in coming to my store today. And in the process of trying to be helpful, I'm going to interview you and ask you lots of questions, which may or may not end up changing your motivation for using pastel purple in the first place. All right, you get the idea. The third fundamental principle of motivational interviewing is compassion, having compassion. So having compassion recognizes client challenges, particularly in the treatment of co-occurring disorders. If a person is in treatment for a co-occurring disorder, that client inevitably has had an enormous number of challenges throughout the course of their lives. Otherwise, they wouldn't be in a treatment setting. And so recognizing these challenges as legit with all of the difficulties that comes with, emotionally and cognitively and relationally and everything else. Compassion is giving primacy to the client's welfare and the client's wishes, and not personalizing. The co-occurring clients in particular, often have the highest rates of behaviors associated with resistance in a treatment setting. And many times they may be emotionally dysregulated. I'm speaking particularly of people with co-occurring substance use and mental health disorders. And sometimes they're not such a nice mood. And so having compassion for the clients is not personalizing if the client's being snappy and resistant and irritable with me. And I'm recognizing that the client's in treatment for problems that they've not been able to adequately solve at this point, which I'm sure is frustrating for them. And this may show up as acting out or resistance types of behaviors. And then the last one, as mentioned previously, is evocation, using targeted questions and affirmations to help the client develop his or her own goals by calling forth their internal wisdom, values, ideas, and plans. Rather than communicating, quote, I have what you need and I will give it to you, the underlying message from the counselor in motivational interviewing is, quote, you have what you need and together we will find it. That is not a quote that I made up. That is a quote from the textbook Motivational Interviewing and the Treatment of Psychological Problems by Miller, Rollnick, and a third author by the name of Hal Arkowitz. All right, so let's talk about some specific kinds of interventions that we do when using a motivational interviewing approach. So the first one is the Oars of motivational interviewing. This might be the aspect of motivational interviewing that people know most about, or most people know about. So using the Oars. Using the Oars of motivational interviewing, it's a particularly apt acronym, as we'll cover in here in a second, for when you're feeling stuck. I don't know what to do with this client. I don't know what to say. I don't know what to do in this particular situation. Recognizing that oars are a way to get moving. So if somebody is in a rowboat and they are stuck, the oars are the way to get yourself unstuck and start to get some progress. So the O stands for open-ended questions. The A stands for affirmations, or affirming the person's goals and strengths. The R stands for reflecting back, or reflective listening, what you hear the person saying to clarify and assure you heard him or her. And the S is summarizing the problem and identifying the first steps. So those watching this video, and if you are in City College and you're taking you're watching this video for the purposes of a course, there's a YouTube link down there in this slide. And that goes to a really good depiction by Paul Burke, no relation to me, a Canadian psychologist, does a cute puppet-related dialogue showing reflective listening and summarizing. All right, so let's take each of those in turn. Open-ended questions. A close-ended question is one that can be answered with yes or no. Do you want some broccoli? Yes. Or a short response like good. So how are you today? Typically the response you're going to get from somebody is good. A good open-ended question, by comparison, is a question that cannot easily be answered with a simple yes or no response. And so the O in the Oars is to use open-ended questions, a question that cannot be easily answered with yes or no. Good open-ended questions are designed to cast a broad net and prompt a more detailed answer from the person responding. And good open-ended questions naturally lend themselves to a longer conversation, which in a treatment setting can be used to get more detailed and descriptive information from your clients to assess and plan for the next steps. Most of the time, a good open-ended question is going to start with what, why, or how. So a what, why, or how question is difficult to answer with yes or no. And those questions are going to be designed to get more information. An affirmation, or to affirm someone, is to offer emotional support or encouragement, or essentially give them a praise. So affirmations acknowledge struggles, successes, skills, strengths, goals, and values. And what we're going to do is notice and appreciate a positive action that the client is taking to address any of those things. The phrase being catch the client being good. So some example affirmations: commenting positively about a behavior. Wow, you're being really open and honest right now. A statement of appreciation for the person. I really appreciate your willingness to participate today. Highlighting doing something right. That's awesome. I'm so glad that worked out. Giving a compliment to build self-confidence. I really like the way you said that. It's insightful. And an expression of hope, caring, or support. I really hope this weekend goes well for you. So these are all examples of affirmations. One of the things that Miller and Rollnick talked about when in their first textbook, I believe, was the importance of affirmations in encouraging motivation, because in a treatment setting, most of the time there's a focus on problems. And so with the client, I'm coming into treatment because I have problems, and then I do an assessment where we talk about and assess my problems, and then I develop a treatment plan to work on my problems, and now I'm supposed to be working on my problems, and it's all problems. And focusing on problems all the time is kind of a big bummer. And so the idea here is that the counselors can really be helpful by finding ways to give praise or affirmations, encouragement, catching the client doing something well, and then shining a spotlight on that and really bringing it out to the forefront, because that highlighting of affirmations makes it feel better, like it's not all problems and there's some improvement here. Now, reflective listening, which talked about in more detail in another lecture, for the group class, the group counseling class. We'll touch upon it briefly here. It's the skill of listening carefully to another person and repeating back to the speaker the heard message to confirm receipt and clarify it as needed. So what it basically means that when you're using reflective listening and motivational interviewing, you're stuck and the client tells you something and you simply repeat it back to them that you heard that. You know, I'm so frustrated. I'm just so frustrated. I don't know what to do and I don't even want to be here right now. So a non-motivational interviewing counselor might start giving advice, trying to solve the problem, whereas a motivational interviewing counselor may just use reflective listening. Wow, I hear you. Sounds like you're feeling really super frustrated and you don't know if you want to be here right now. Reflective listening can be really powerful that way. So in repeating it back, I'm confirming to the client, I heard you. And I'm not doing anything else other than acknowledging I heard you and I'm with you as you've said whatever it is that you said. It can sometimes also, though, serve to correct and clarify, which might be really important. You know, so maybe the client doesn't say it quite like that. Maybe the client just says, I'm just so like, God, it's like the freaking work and clients, I'm over it. Right. So maybe I say, wow, you sound really angry about being in treatment right now and all the assignments and the clients, and you're really over it. Well, no, I mean, not angry so much. I'm just frustrated. So that's really important, because if I'm assuming the client is angry, then I may start to intervene, you know, based on anger. And by using reflective listening, I get a clarification that it's not anger, it's frustration, which I wouldn't have known had I not done the reflective listening. And studies have also shown that when we use reflective listening and repeat back to people, it feels good. It makes them feel heard. And most of the time, what we're going for in a reflective listening is, yeah, exactly. Now, when you're doing reflective listening, you can repeat all or part of what the client just said. So sometimes referred to as mirroring, which is literally using the same words that the client used and just repeating it back. But you can also paraphrase and make an interpretation of what the client's feeling. Typically, that is the more advanced and effective aspect of reflective listening, which is not just parroting back to them their exact words, but paraphrasing, getting the gist of it, and then really listening hard using active listening to try and understand the feeling or the emotion that's behind what they're saying, and then making an interpretation of what that feeling is. Regardless, the goal is to clearly understand their perception, reflect that understanding back to them in a way that lets them know that you heard them and understand them, encourage them to continue communicating with us. And reflective listening also paves the way for other targeted interventions, typically because it lowers resistance. So reflective listening can be super powerful with a resistant or upset client. Client says to you, this is stupid. I don't want to be here. I don't know why I can't get a pass, this weekend to leave. I've been here for a month. I put in all my work. This is just stupid. This whole program's stupid. And I don't even want to be here. The only reason why I'm here is because the judge said that I had to be here. If I try to do an intervention with this client now, while they're in this state of anger and agitation and irritation about the program, it's going to fall flat. They're not going to be open to listening to this. Whereas if I simply repeat back, like, okay, I hear you. Sounds like you're really upset and you're frustrated because you feel like you deserve a pass. You've been putting in your time, you've been putting in the work, and you didn't even want to be here in the first place. You're only here because the judge told you to do that, but you've been putting in the work anyway, and that should be rewarded. Yeah, exactly. Well, as soon as that client does the yeah, exactly, it drops the wall. It drops the resistance somewhat. And so now if I turn around and say, okay, so how should we handle this situation? What's something we can do? Have you addressed the issue about the past? Tell me more. The client's going to be more apt to talk with me once I've done the reflective listening intervention. Okay, and then the S in the R's is summary statements. So a summary statement is kind of like reflective listening, but whereas reflective listening just takes a part or a fragment of something that was just said and repeats it back, again, sometimes in the goal of being able to lower defenses to do an additional intervention. Summarizing is a much bigger type of reflection where you're confirming you've been listening to everything they said. So a summary is usually more than just a fragment of what was just said. It's the theme of what they've been talking about, or summarizing the entire conversation that you've had. You've had a 45 minutes of a 50-minute individual counseling session, and you say, okay, all right, we've talked about a lot today. Let me just repeat some things back to you to make sure that I got all the key points, and then we give a much larger summary. So summarizing reflects material back to the speaker in a way that's shorter, and it provides a more succinct or brief and clear understanding of that. And a good summary also provides an opportunity for the individual to reflect on what it was that they just said. Summaries also can be used to link together and reinforce material that's been previously discussed. So I'll use the example, the person is really angry about the pass, right? So, just, this is stupid, I don't want to be here, and blah, blah, blah. Like, yeah, no, I hear you. Sounds like you've had a really frustrating couple of days. I mean, there's been a lot of stuff going on. I mean, they said you were late on that one assignment, and you're not. I mean, you had that done. It was a counselor mistake. You put in the effort to finish everything, and you put in for a pass thinking you're going to get it, and you didn't get it, and it feels really unfair to you, and you're thinking of leaving the program. This reminds me a couple of weeks ago when we were talking about a situation you were having, you remember, with that other client in the group, and the two of you were just kind of really going at each other, and it was making you really upset, and you were thinking about leaving then. I'm wondering, maybe we can just kind of talk about what you did then, and if there's something we can apply to how to handle this situation now. So you can see it's a much bigger reflection. It's not really reflective listening so much as just summarizing important points, and in this case, linking that to another previous important point for use in an intervention. Okay, change talk. So change talk is anything that the client says that may signal a move towards openness to change. Change talk is compared to sustained talk or resistance talk. So sustained talk tends to justify the current position, whatever it is. Whatever it is, like it's too much trouble to do anything about this. Resistance talk often is in the form of I can't do it, or I won't do it. Whereas change talk, the client may say things like, well, I mean, I really want to do something about this, or I don't know, how do I do this? Or I guess I'll try to do this. So the differences between those three are really super important. And a motivational interviewing counselor is going to have their ears open, listening for change talk, things the client's saying that might suggest that they're willing or able or about to do something to make a change. So change talk is literally the client talking themselves into making changes. So some change talk is preparatory. That means is that it's indicating openness towards the idea of change without really committing to it. So if a client's saying, I wish I could change this situation, or I mean, I don't know, I'm able to resist the temptation sometimes, but just sometimes it's too much. Or, I mean, my husband would be really happy if I would get a job, or gosh, I don't know, but something has to change in this situation. So in this case, the client is telling you, the counselor, that they're mentally there. Their motivation to do something about this is up. It's not complete resistance. They may not be taking action yet, but they're preparing in some way. Other times, change talk is mobilizing. They'll say things that suggest they're ready to take action. So yeah, like, after listening to the others in group today, I think I'm going to also write whatever, or yeah, I'm willing to do this, or I mean, I guess I could do this. So either way, what we're seeing in all of these is the client essentially gearing themselves up, trying to convince themselves, getting ready to do something. So responding to change talk then becomes a really super important intervention for the motivational interviewing counselor. So you decide basically not to respond to anything that's essentially a form of resistance. So if the client is saying, I can't do this, or this is totally unfair, right? I'm just listening, I'm listening. And what I'm going to do is wait and instead respond to and highlight anything the client says that indicates the possibility of change. So essentially, you're letting go of anything that's going to lead to no, and instead you're trying to catch a path to yes. So if the client is saying, this is just, it's ridiculous. Like, I'm not going to stop smoking pot. This was dumb. This was a stupid idea. Pot's the only thing that works for my anxiety, and I'm sick of it. Like, and it's not, and who cares? It's legal, like, just, God, I don't know why everybody's giving me such a hard time about this. My medication isn't really working for me anyway, so there's that. So I'm going to ignore, right, all the resistance talk and say more about that. Your medication is not really working for you anyway. What did you mean by that? It's just like, it doesn't work. The psychiatrist switched my medications and it doesn't work. I'm still having all kinds of anxiety. Okay. And did you talk to the psychiatrist about this? No, I haven't talked to, I have an appointment with him next week. I guess I should probably tell him that. Yeah, right. So now what I'm going to do is I'm going to focus my intervention there, because I'm not going to quit smoking pot is a form of resistance. So I could try to address that with the client, but that's going to be like, trying to move up a brick wall. It's going to be really hard to get any movement. And so I just listen, acknowledge, waiting, right, until this piece about the medication not working. I guess I should talk to the psychiatrist next week. That indicates preparation. And so we're going to focus the intervention there. Now, you can also evoke change talk. So when a client is, being resistant or not showing motivation, you can simply use open-ended questions, focused open-ended questions. Well, what are some ideas you already have? What are some resources you have that could assist you? Well, pretend you're trying to convince me. Why should you make this change? If an expert was giving you advice, what might they suggest you do? So the idea here is to move the client out of a resistance talk, I can't do it, I won't do it, into a change talk. I might do it, I could do it, I guess I'm willing to do it. Okay, so for those of you who are watching this video as part of a course at San Diego City College that you're receiving credit for, this is the keyword or the key phrase non sequitur. So you are going to be tested upon the completion of this video, and one of the questions is going to ask for the keyword or the key phrase. The keyword or phrase will not be on the PowerPoint slides, and the student's only going to know this keyword or phrase if they actually watch the video. So the key phrase for this video is, motivation is a coin with many sides. I'll say that again. Motivation is a coin with many sides. All right, let's get back to our lecture on motivational interviewing then and talk about developing discrepancy. So developing discrepancy goes directly at the issue of ambivalence, and ambivalence is everywhere in a treatment setting. It is normal and it is expected. So the definition of ambivalence is simultaneously wanting two things that are in conflict with each other, and we anticipate ambivalence in treatment. If there was no ambivalence, the person probably wouldn't be in treatment. And so when you have ambivalence, what you'll often hear then is the client voicing both sides of the ambivalence. I don't want to get any more DUIs, but I don't want to quit drinking. And so what you're hearing there is two different sides, right? I both do want this and I don't want this. I don't want to upset my wife, but pot helps me with my anxiety. And so when we're working with clients in a motivational interviewing framework, what we're going to do is accept the ambivalence as fact. It is what it is. And now what we're going to do is we're going to amplify the ambivalence. We're going to start to ask questions about the ambivalence, not tell them what they should do, give them advice, etc. But what we're going to do now is start to ask questions in a motivational interviewing process. This is where the treatment begins. Typically, though, this isn't what happens. So many times when faced with ambivalence, it's the counselor's reflex to respond with the right answer. The client is saying, I don't know how to get sober. I don't know if I can get sober. Well, you should get a sponsor. So using a should when a client is in a state of ambivalence, they will inevitably counter respond with the opposite of what's just been argued. And so if they both want to stop drinking, but they don't know how, and some other part of them doesn't want to stop drinking, and I tell them to get a sponsor, then they're probably going to start to tell me all of the other side. I don't like sponsors. I've had bad experiences. I don't need anyone else's help. I don't believe in AA. Well, why don't you get one since you want it? Right? This is not helpful for the process of treatment. And so a motivational interviewing approach to counseling means that you are looking for and you have your radar attuned to ambivalence. And when somebody expresses ambivalence, do not take one side over the other side. Now, again, everybody who's listening to this lecture has had times in your life where you've been ambivalent. Should I enroll in the AODS program or should I not enroll in the AODS program? Should I rent that apartment or not rent that apartment? Should I call that person or not call that person? I kind of like them. And what that means is you're pulled in two different directions and you can make the argument for both sides. So I do want to enter the AODS program, but that would mean a commitment, going to school and how's it going to affect my work? And I've got kids, right? I'm ambivalent about this. I forgot what my other second example was. I'm sorry. My third example, was, should I call that person or not call that person? I was out at a party. I met someone. I'm single. I'm feeling a connection with this person, and so one side of me is like, yeah, I should totally call her. Or I guess nowadays people would be texting, but whatever, right? I should reach out. Like, no, like she was just being nice. I shouldn't do that. Like, no, I totally should, because I think we had this moment. Like, no, I think she was smiling to everybody else at the same time. So when you're ambivalent, you can already argue both sides of the coin. And so as soon as somebody else then comes in and takes one side, you go to the other side. So if you're ambivalent about whether you should enroll in the AODS program or not, and somebody says, you shouldn't do that. You already have a good job. Like, why would you do that? It's more work to go into school. You're probably going to respond with, well, because I think I make a really good drug and alcohol counselor, and I'm really very interested in this, and I want to be helpful. But take the same scenario, and your friend says, oh, you totally should roll in the AODS program. Well, but I already got this good job, and I got kids, and that's going to make things really challenging. And so it's sometimes referred to as the taking sides trap in motivational interviewing, and it directly relates to developing discrepancy. So when you see discrepancy and or ambivalence, where there's a conflict or a lack of compatibility between two goals, the first thing you do as the counselor is communicate acceptance of the ambivalence. So this is a different scenario. So somebody is in outpatient treatment. They haven't drank now in 5 weeks, and they've got tickets to the San Diego Padres game, which is a baseball team here in San Diego. And so they say, I really don't want to drink. I've got, 5 weeks. I just took my 30-day coin, but my friends don't know I'm in treatment, and we always drink when we're at Padres games. And I don't know, it just fills me with anxiety thinking about it. And so the untrained counselor would say, oh my gosh, you totally should just tell your friends that you're in treatment and not drink, right? Because you've been doing so well in this program, and there's nothing that you should feel shameful about that. Well, then the client's going to turn around and argue the other side. So instead, in developing discrepancy, what the counselor will do first is communicate acceptance, often with some reflective listening. Yeah, I get it. You don't want to drink at the Padres game this weekend, but you feel like that might make a big issue with your friends and increase your anxiety. Yeah, exactly. And so now we explore with the client. So we're not judging them. We're not making a decision for them. We're not arguing with them. We're just going to explore with them. And so this is the developing discrepancy part. Like, yeah, all right, that is a tough issue. Let's talk of this one out. And so what the counselor is typically going to do then is, again, without telling them what to do, explore the issue in a number of ways. First, exploring how important this is for the client, not for you. So we know that when clients don't see it as an important issue, then their motivation is lower. So we may say, like, all right, well, on a scale of 1 to 10, how important is it for you not to drink this weekend? I don't know, like a 6, I guess. Like, yeah, wow, okay, 6. So it sounds like that's pretty important to you. Like, okay, and now what we're going to do is we're going to move into the pros and cons. So, well, what's the risk if you do drink, right? What's going to happen if you go and you have a couple of beers? And what's the risk if you don't do that? What's the benefit if you do drink, right? What's the benefit if you don't drink? And so what we're going to do is we're going to explore the pros and cons. And again, we're just developing discrepancy. We're not answering the questions for the clients. We're going to ask, like, when you weigh those two things out, like, what stands out to you? Now, one of the advanced ways of developing discrepancy when you as the counselor do have an idea about what you think the right choice would be, at least clinically, is not to tell them that, because I don't want them arguing the other side and reinforcing the other side. I'm going to develop discrepancy, but I'm going to wait for change statements or change talk. So if they're like, yeah, I don't know, I guess just a couple beers won't be that big of a deal, I guess. Yeah, so I mean, a couple beers, may not be that big of a deal. But let's talk that out, right? So if you have a couple of beers, I mean, how does that affect things with you and your friends? Well, I mean, they're not going to really know anything different. And how does that affect then some of the people that you're in treatment with? I mean, you took the coin the other day. Like, are you going to tell the people you're in treatment with? Oh man, yeah, like that's the thing. I don't know. I don't want to like, no, like, I don't know what to do. All right, well, I mean, let's look at that again. Now we're back to like asking questions, and now maybe our client says, yeah, I don't know. Like, I mean, I guess if I just, told them that I was driving and that's why that might work. Yeah. Okay. So that's a solution, right? I mean, you don't have to tell them about being in treatment. You could just say that you're not drinking because you're driving. And it sounds like you feel like your friends would accept that. And so here, I didn't respond earlier when it was still leading toward, I guess I could just drink, it's not a big deal. I kept trying to develop discrepancy until now I got something that sounds like change talk, and change talk that I'm supportive of with my client for their greater welfare. And so now what I may do is try to move into that as a treatment goal. So the pros and cons matrix, is just what do I gain if I don't make this change? What do I lose if I don't make this change? What do I lose if I do make this change? What do I gain if I do make this change? So pros and cons. And the idea here is that if you stay with the discrepancy for long enough through exploring it with a client, then the client often becomes uncomfortable enough with the discrepancy to make a decision for themselves, which increases motivation because it ultimately came from them. So using the example that I just gave you, if my client comes up with the idea that he's willing to tell his friends at the baseball game that he can't drink because he's driving, and that's all he's willing to do today, and that's all he's comfortable with, hey, that came from him. And so I'm going to support that. And I may have thoughts about whether or not he should be honest with them, or I may, have thoughts about whether or not, ultimately long term that's going to work. I mean, I might have lots of thoughts, but using a motivational interviewing approach, my client is in a state of ambivalence. I'm going to develop discrepancy with him, and if he comes up with a solution that works, then we're going to go with that. Okay, rolling with resistance. In addition to the Oars, this is one of the things that many people know about when they hear about motivational interviewing, rolling with resistance. So rolling with resistance from a client is normal. We should expect it. When somebody's feeling resistant, there's a lot of reasons why they might be resistant. They may be in a state of ambivalence. They may not be ready to do something. They may be uncertain about how to do it. I mean, there's many, many reasons why a client might be resistant. And so we should simply expect that. The problem is resistance from the counselor is bad therapy. And resistance from the counselor usually means we're not meeting the client where they're at. We're not supporting their thoughts and beliefs and goals, right? We are being resistant to how they see it. And so when resistance settles in, if a client's feeling resistant and I'm resistant also, then that creates a tug of war, and usually the client's going to dig in, which is not helpful to increase motivation. So there's many ways that a counselor can be resistant. Arguing with a client is a form of resistance. I'm not willing to hear what you have to say. Instead, I'm going to argue my point. Interrupting a client. I'm not listening to the client, right? I'm cutting them off because I've got something that I think is important to say. Negativity towards their ideas. That's never going to work. Blaming the client. Your drinking's causing lots of problems for you and your kids. Disagreeing with the client, I mean, kind of related to arguing, but in this case, the client comes up with an idea and I just like, yeah, I disagree. I think that's not going to work. Ignoring or withdrawing, fine, go ahead, do it your own way. Good luck. Refusing to comply, like, I'm not going to support that plan. If you do it, then we're done here. And then obviously name calling and sarcasm and put downs, like, oh, that's a brilliant plan. Do you like going back to jail? So these are all aspects of counselor resistance. And so the idea in rolling with resistance is not to meet the client's resistance with your resistance. That's not going to increase motivation to change. So instead, don't challenge the resistance. It's very similar to developing discrepancy, where you simply accept the resistance and you communicate that. Okay, I hear you. You don't want to quit using right now. So we don't fight with whatever the resistance statement is. Once we've accepted, okay, that's what your position is. Now what we're going to do is see if we can reframe this, or suggest a different way of looking at the issue that might develop discrepancy. So if the client's like, I don't want to quit using right now, like, and maybe it was an intervention, the client's wife, got a couple of people together and intervened, and the client had to do treatment, right? Or there was going to be some consequence. He'd have to leave the house or something. So the client's in and is like, I don't want to, quit using. I mean, this is stupid. Like, it's not a problem, blah, blah, blah. So I'm going to see that as resistance. Say, okay, yeah, I hear you. So it sounds like you're thinking you don't really want to quit using right now. Yeah, exactly. Okay, yeah, I get that. We should talk about how this is going to impact some of the issues that your wife brought up in our last family counseling session. How are we going to handle this? I'm not resisting it. I'm not fighting with the client. I'm not arguing with him. I'm not trying to persuade him, convince him, give him advice about why he should quit using. I'm simply rolling with the resistance. And now I'm going to see if we can look at the situation in a different way. So another aspect of rolling with resistance is to really emphasize individual choice and control. So client comes into my treatment facility and, says like, yeah, no, I'm gonna smoke pot. Like, pot's legal in California, and I have a medical marijuana card, for my anxiety. And so, like, I mean, whatever, like, I'm not gonna use meth, but I'm still gonna smoke pot. So again, the rolling with that is like, okay, so it sounds like that's really important to you. That smoking pot is important for your anxiety, and you're right. You can definitely smoke pot in California now that it's legal, but there's rules in this treatment facility that there's no tolerance for any drugs or alcohol, legal or not. And we UA people who are in our treatment program, and if you come up positive for marijuana, then you won't be able to stay in the program. So how do you want to handle this? Is this the right program for you? Do you want to look at a different kind of program that's practicing more of a harm reduction approach? What can I do to be helpful? And so I'm just rolling with the resistance, and I'm emphasizing individual choice. Like, no, like, I want to be in this program. Yeah, no, I hear we got a real dilemma here. So like, on the one hand, you want to smoke pot and you got really good reasons why you want to do that. But on the other hand, it's not going to fly because it goes against the program policy and procedures. And so I don't know, what kind of solution can we come up with to rectify this? So motivational interviewing, emphasizing individual choice, rolling with the resistance. So the other thing we can do when a client is entrenched on an issue is to shift focus to something that the client is willing to change right now. I'm trying to think of an example. So if a client is really insisting that they are not going to do a relapse prevention plan, this isn't school, I'm not going to do homework, and I'm not doing a relapse prevention plan for whatever reason. Like, so I can explore with that client about why they don't want to do a relapse prevention plan. I talk to them about, that being a program requirement. I mean, there's all kinds of things you can do, but the client's not budging, right? I'm not going to do this. And so research into motivational interviewing has shown that when somebody's super resistant to one thing, if you leave that alone and shift focus into something that the client is willing to do, then you can come back to that later. So maybe I say to the client, like, okay, so it sounds like you're not willing to do the relapse prevention plan and you don't care. That means you won't successfully graduate from the program. I'm wondering, does that mean you don't want to do any of the assignments that you have to do in the program, or is it just the relapse prevention plan? No, I'll do the rest of them. It's just stupid. I don't want to do a relapse prevention plan. I don't know why this client is so resistant to a relapse prevention plan, but okay. So you are willing to do some of your other assignments. Yeah. I mean, the autobiography assignment, that seemed like pretty interesting, so I'm willing to do that. Okay, great. Well, let's talk about that. Have you started working on that? And so what I'm doing is rolling with the resistance to the one assignment, and I'm going with the fact that there's no resistance to doing this other assignment. And now we're trying to be collaborative and see if we're helpful. Many times when you do that, you then can go back to the one that the client was so resistant about, and things might have changed a little bit for the better. Okay, And then supporting self-efficacy. So supporting self-efficacy is recognition that if a person believes that they can actually make a change, it helps them to keep motivated. Now, the client, not the counselor, is ultimately responsible for choosing and carrying out a plan to try and change. So we need to try and help them get up with help them come up with their own plan, as we've said. And there's no right way to change. And if a plan for change doesn't work, then clients and counselors can work together to try something different. The idea here is that we are going to support the client's ability to solve their own problems and come up with a plan that's going to work for them. So part of supporting self-efficacy is creating a safe space for the client to explore difficult issues and engage them in conversations that help them believe change is possible and attainable. Meaning that I should not be a source of stress as the counselor. Hopefully, being in a session with me, we've created a safe space where the client can talk about how hard it is to do this, or they're unsure about doing this, or they're ambivalent about doing this. And we're going to engage in conversations and questions to help see if we can motivate and believe that change is possible. So these principles of self-efficacy then are that we're supporting the client's autonomy and preferences. We are going to recognize the client has strengths and we're going to highlight them. We're going to focus on interventions to try and help the client stay motivated and believe in their ability to change. Now, in a practical sense, supporting self-efficacy often means that we need to acknowledge the client's concerns. Clients are in a state of ambivalence in treatment facilities. They're going to have some concerns. We're going to acknowledge them. We're going to use reflective listening and summarizing to say, yes, I hear you, without focusing on the negatives. We reframe and highlight the client's successes and strengths. So find things, going back to the affirmations, find things that we can catch that they're doing well in. Use those for praise in order to try and encourage motivation. We're going to communicate to the client our recognition of the small steps that they've been taking in the process, where their successes are, and we're going to be encouraging and ask about what the next steps are. So here's some examples of what that might look like. So clients like, I've been in 7 treatment programs before, like this just doesn't work. I finished treatment, but then I go out and use, and it's just stupid. I'm never going to get better. Like, yeah. That sounds frustrating. I can see that you've been in 7 treatment programs before. I'm also seeing that you were able to put together 6 months sobriety at one point. So let's talk about that. How were you able to put those 6 months together? So here, supporting the client by acknowledging the difficulties without focusing on them, and then finding a strength and using that to attempt to try and motivate change. Here's another one. So even though in the past week you've had some anxiety attacks, you haven't had any panic attacks. So that's great. What's the plan for next week? So maybe the client has a treatment goal, to be practicing deep breathing in order to lower her anxiety. And then she comes into treatment talking about how this isn't working. I still had anxiety this week. This is stupid. I don't know why I'm doing this. So did you have any panic attacks last week? No. Okay, great. So even though you've had some anxiety this past week, you've not had any panic attacks. So I'm supporting the client's self-efficacy and ability to make changes by highlighting what is working. And then the last example, it sounds like you've decided to try a support meeting. Good for you. Can you tell me how it went when we meet next Thursday? So here in supporting self-efficacy, it's recognized that the client has presumably used change talk to say they're thinking about going to a support meeting. What I'm doing is really highlighting the fact that they've made that decision. And some of the accountability is that I assume they're going to do it. And so now it's, can you tell me about it when we meet next Thursday, which is me showing support for the fact that I believe that they're going to get this done. All right, that takes us now to the end of our presentation and the last slide. There is more to motivational interviewing than the things that I went over today, but these are some of the important aspects of motivational interviewing. And there are lots and lots and lots and lots and lots of books and articles and videos and trainings out there on MI. And I encourage everybody to go to as many of those things and read as many as possible, because there's definitely a lot more to learn about motivational interviewing. But here's some of the principles that we reviewed today. So the first one, affirm and express empathy. This is honoring client ambivalence and meeting them where they're at. No advice giving. Motivational interviewing counselors do not give advice. It doesn't work. It builds resistance. So instead, we are going to evoke solutions from the expert, who is the client in this case. We talked about the importance of responding to change talk and ignoring sustain or resistance talk. We also talked about rolling with resistance, avoiding arguing or judging my client, accepting this is the position that they're in right now, and emphasizing personal choice in the matter. We discussed developing discrepancy, recognizing that there is discrepancy or ambivalence, and then really highlighting what the client wants out of this, what their goals are, their behaviors, using a pros and cons list in order to attempt to help them to make a decision. And then we talked about supporting self-sufficiency, being a cheerleader, supporting clients' autonomy. Okay, that brings us to the end of the motivational interviewing lecture today, with the stare there, the movement from I won't do it to yes, I did it, as an example of the continuum of motivation. So as always, I hope you found this lecture helpful. If you are watching this on YouTube, you are welcome and encouraged to use the comments and reach out to me if you have any questions. And for those of you who are watching this lecture for credit at San Diego City College, you have my email and presumably access to me in the class. If you've got any questions, follow up, and I'll be happy to follow up with you. Thanks for listening.